That's an improvement. Audio, that's struggling.
Where was the wreck?
Audio, people complaining.
Yeah, I didn't even have audio until we hit the video button. Now I'm getting this here.
I unmuted, so
So she said, there's just the screen sharing still, right?
you're waiting for Ashley to allow us to share our screen.
So we're a participant, right? So can we just log in as Ashley? Can you give us?
No, she's the host. She's hosting it. She's on her computer. She has to allow
Right.
screen sharing.
So she just has to go to,
Should be the settings.
there we go, got it.
Okay.
Yeah, that's it.
Okay. This one?
Yeah.
Oh, I got it. You know, actually, 15 minutes late isn't bad for what I'm working with.
Good.
All right. You have me off mute, right?
Sure.
I'm off mute.
Yep, that's.
Appreciate
Okay.
your patience. Sorry.
All right, welcome everyone to Grand Rounds.
Well,
Yeah, I
somehow-
can do this. Yeah.
Yeah, there we go. Okay.
I'd like to welcome Dr. Patrick Stevens. He's going to be talking about the evolving role of cardio-oncology. What is it and why should we care? Dr. Stevens has been with us for, I think, 3 years now, 3.5 years, and came from Vanderbilt University, where he also focused on cardio-oncology there. He's been instrumental in taking over our heart failure population and leading the cardiology division in cardio-oncology. Thank you so much, Dr. Stevens, for presenting today. Thank you.
Thank you, and I appreciate everyone for their patience. Zoom sure is fun, so nobody over. So I'm going to be talking a little about the evolving role of cardio-oncology in practice. You know, when I went to residency, I had every intention of going through into oncology. You know, I'd done research in med school in oncology. I'd really had a lot of mentors in that field. And as I was going through, I really kind of fell in love with the clinical aspects of cardiology and heart failure in particular. And I really struggled with the decision on what to do for quite a while until somebody said, you know, hey, there's this thing called cardio-oncology where you can kind of do both to some degree. And so I started doing research in that, and it really kind of spoke to me because you can take care of some really sick oncology patients, really help the oncologist take care of these patients and improve outcomes down the road. So I'm going to talk a little bit about some cancer epidemiology so we kind of understand where we are with treatment of cancer, an overview of what cardio-oncology actually is, because that's kind of what we're talking about, how big a problem it is, some of the short-term, long-term effects of therapy, what we can do, and who you should think about referring. So I think it's always helpful to have some cases to kind of illustrate what we do exactly. So this is one of my patients since I've been here. She's a 68-year-old female. She had a history of retroperitoneal liposarcoma. She'd had resections twice in the past. For some pretty big masses. She'd had, I think, you know, football-sized masses both times. And she went to her oncologist and she had recurrence of this with progressive growth. And the concern was, you know, she's been resected twice, a third time, probably not ideal. So they decided to start putting her on some chemotherapy. And one of the kind of the backbones of sarcoma therapy is doxorubicin, which she received a dose of 75 milligrams per meter squared, with basically a plan to just keep giving this medicine to her until she couldn't tolerate it anymore. And so they sent her to me to monitor her because she had a history of atrial fibrillation and hypertension. And so her echo after 4 cycles of chemotherapy showed a normal EF, a normal global longitudinal strain, which is one of the things we look at that can predict drop in LVEF prior to it happening. So we decided to continue on her therapy. She had a couple more cycles. After cycle 6, her EF had dropped a little bit, down 5%, and her global longitudinal strain had dropped. At that point, she was also a little bit symptomatic, so we stopped her chemotherapy. We started on a beta blocker and an ACE, and even though she'd stopped her chemo, her next EF showed a significant drop in her EF, but because we'd held therapy, she recovered within 3 months, was back to normal, felt great. And so this, was a pretty good save, because if you continued through, the likelihood is you'd hit an irreversible point with that chemotherapy where she wouldn't have recovered. So what exactly is cardio-oncology? Well, it's not the treatment of cancers in the heart, which is what some people think. It's actually just the general clinical overlap of cancer and heart disease. And that includes a lot of things. You can have cardiomyopathies from radiation, from chemotherapy, pericardial disease, particularly from long-term effects of radiation therapy, valvular heart disease, vascular disease from some of your tyrosine kinase inhibitors, hypertension, thromboembolic disease, and then arrhythmias and QT prolongation. And so there's quite a few medications that can cause quite a few cardiac issues that have to be monitored. So the general goal that we have is to identify who's high risk for the therapy to begin with, and then find ways to detect cardiotoxicity before it happens. I think that first case was kind of an illustration of that, to catch it before it gets really bad. And then to find ways to prevent cardiotoxicity in high-risk patients. I think this is one of the keys. The last bullet point is to assist the oncologist to give the drugs they need to give. It's not about telling them to stop giving medications necessarily. It's about finding a way to get the patient the medication they need in the safest way. So it's never the cardiologist's job to step in and say no. And in fact, in the guidelines that they have for cardio-oncology, it's supposed to be a deliberative, team-based approach to give medication safely, because treatment holds, even relatively short treatment holds, have shown to have worse long-term effects for patients. So who are the patients we look at? I think it falls largely into 3 classes. So those who have existing structural heart disease, your heart failure patients to begin with, are patients with a lot of risk factors. They're developing cardiac events prior to starting chemotherapy. How do we take care of them before and make their chemotherapy as safe as possible? How do we think about giving them safe chemotherapy? The second population is those who develop cardiotoxicity during their therapy or radiotherapy. And then a large group that a lot of times gets ignored is the cancer survivors who develop chronic disease from prior chemotherapy or radiotherapy, particularly our pediatric population as they become adults. So incidence of cancer generally has decreased in men. That's largely because of a decrease in prostate cancer diagnosis as we've kind of moved away from that, but remained relatively stable in women. It's driven by an increase in incidence of breast cancer, probably again from better screening. Breast cancer itself accounts for about 25% of cancer in women. Now, mortality generally has dropped over time. Cancer mortality accounts for about 25% of all deaths, and 30% of those are coming from lung cancer. Mortality has decreased both in men and women, and breast cancer mortality has decreased by 1.6% in women. So overall, if you're looking at your 5-year survival curve, you have an increase from about 50% to 66%, which over 20 years translates into 1.3 avoided cancer deaths. Now, when you think about that, what that means essentially, for the cardio-oncologist is that you have a lot of potentially pretty sick patients who are living longer. I think one of the issues, with oncology in general is that most of these people died before they had a chance to really display a lot of the long-term side effects. But as we get better and better and better at treating the patients, you have them living longer and seeing the potential downstream effects of the therapy that they are receiving. So again, why is that important? It's kind of like we said, if you have a pediatric cancer survivor, they are 15 times more likely to develop heart failure than an age-matched sibling, which is a pretty incredible number. In Hodgkin's lymphoma survivors, cardiomyopathy is the leading cause of death after 20 years from diagnosis. And these are people, who are diagnosed in their teens to 20s. And so this is something we see not infrequently. that you have a cancer with a pretty good survival rate, and then you have really debilitating disease 20 years in the future when the patient's still pretty young, and it's finding a way to protect that patient from those long-term outcomes. At this point, there's an estimated 5 million adult cancer survivors at a high risk of cardiomyopathy due to exposure to anthracyclines alone. There's probably some degree of a multiple hit involved in that. So the anthracycline is part of it, but then as you build up risk factors over time, it worsens. And on the other hand, 2/3 of your cancer survivors are 65 or older. They're an increased risk toward getting comorbidities over time. If you look across, various forms of cancer, those who have cardiovascular disease just do worse than those without it. I mean, I think that generally makes sense, but these are pretty striking numbers. And again, if you look at this, I think this really illustrates the point, particularly if you look at your Hodgkin's lymphoma patients. Most of these patients have excellent survival, long-term survival. But if you look at the survival for heart failure, your 5-year survival is 50%. So, you treat a Hodgkin's lymphoma patient, you give them heart failure, you treat a breast cancer patient, you give them heart failure, you're looking at much worse long-term effects. And so, the goal is to find a way to ameliorate that so that you don't treat the patient and then, give them something that's potentially even worse down the road. And if you look at survival for doxorubicin-induced cardiomyopathy, it's pretty bad when you compare it to some of these other forms of cardiomyopathy that we have. And part of that's obviously the patient population. They're sicker, more frail patients, and they generally don't do as well. But part of this is that this can be an irreversible process as well. So it's something that we have to really work towards avoiding. Now, if you look locally at our incidence of cancer, we're not one of the highest rates of cancer, but towards the middle in terms of our incidence of cancer. But if you look at our rate of death for cancer, it's actually amongst the worst. And part of that is, probably multiple reasons for that, but part of it is that we just have a sicker population than a lot of other parts of the United States. So if you look from some of the CDC data, we have, compared to the national averages in the US, higher rates of smoking, worse rates of appropriate exercise per week, more overweight patients. We have more patients who've had heart disease, stroke. And so I think that kind of indicates that we just generally have a much sicker population than other parts of the states, particularly from a cardiovascular standpoint. So you have cancer patients with a lot of cardiovascular comorbidities that have to be monitored. Now, how do we report cardiotoxicity? Because I think this is kind of one of the struggles with this field. I'm going to illustrate a case to kind of display why it can be a little hard at first to figure this out. So this is a drug called ponatinib. It's used for treatment of CML, and it was kind of a 3rd-generation medication that was used for a specific mutation in CML. And so initial clinical trial from the New England Journal really had no cardiovascular safety profile signal. And this was November in 2012. People sailed through, seemed to be fine. They were followed up for 13 months. So a little later, the FDA approved this on an accelerated basis. At that point, you had an aggregate phase 2 trial that had about an 8% risk of cardiovascular, cerebrovascular, and peripheral thrombosis. Wasn't felt to be that bad. So about a year later, you had another phase 2 trial. And at that point, you had an arterial thrombus risk of about 4.5%. Now, if you took all comers and you ignored treatment-related events, it was actually 16.5%. So you went from basically no events to potentially 16.5%. And then later that month, you had another follow-up on that initial phase 2 trial where it was 24% of arterial events. And then after that, if you looked at the phase 1 data, long-term follow-up, they had 48% vascular side effects. So you had somebody who went, or you had a drug that went from basically 0 cardiovascular safety profile when it was started and approved on an accelerated basis to 48% of the initial patients having some sort of vascular side effect. And this was a drug that was already on the market at this point. And so a lot of times, we don't see these cardiovascular safety signals till it's been out in the market for a bit. And that's what happened here. Is that part of it, people weren't looking for it. Here, 16% of the patient had some sort of vascular event, but only 4% were actually reported through the trial. And so if you're not looking for it, you won't find it. One of the other issues is the way that these events are reported. So there's something called the Common Terminology Criteria for Adverse Events that's used throughout oncology trials. And it's really far ahead of a lot of the other fields, but it does have its issues because a lot of it comes down to semantics. So if you look, say you have a 50-year-old patient with a pretreatment EF of 60%, drops to 35%, but he's asymptomatic. How do you code that? Well, there's 3 different potential ways in these guidelines to code this type of event. So you have left ventricular systolic dysfunction, which in this case you wouldn't qualify for because at least this one, it's a symptomatic drop. But you have heart failure where you could argue this is an asymptomatic cardiac imaging abnormality. So this would potentially be a class 1 event. Or is this an ejection fraction based event, which puts you at a grade 3 event, which is fairly significant. But those 2 things are markedly different. A CTCAE type 1 event is not considered significant. A CTCAE grade 3 event is considered significant. And so depending on how you code this, it actually makes a fairly significant difference when you're looking at the results of a trial. And so that can lead to problems as well. And again, when is an adverse event an adverse event? Well, when somebody says it is. So that was the issue with ponatinib, right? They had 16% arterial thrombotic events in one trial, but only 4.5% of those were attributed to treatment. So someone actually has to think that it's related. And sometimes even if an event is reported, it doesn't count because, again, treatment related. What about on the other side? How do we define cardiotoxicity as cardiologists? Well, that's also problematic because if you look across different trials that have looked at this, you have just markedly different criteria here that they've looked at. And so both on the oncology side and the cardiology side, we're really not meeting a great consensus. And even committees disagree on this. You have the ASC who says different than, I think this is ESMO here. So, the most recent expert committee for multimodality imaging says, and I think this is what most people feel these days, is that it's a drop in EF to a value of less than 53%. I think generally the way I think about it is if it's a drop of greater than 10% or any drop that gets you to less than 50, they use 53 here. And then a change in your global longitudinal strain of greater than 15%. So looking at some of the medications that we monitor, I think the treatment of anthracyclines was really what brought cardio oncology to the forefront to begin with. This is one of the older medications that we use to treat patients. It's really the backbone of treatment of basically all of the blood cancers, your acute leukemias and your lymphoma patients. It's also used for sarcoma patients and in some settings of breast cancer that it's been moved away from a little bit. Now, why is that an issue? Well, part of it's your leukemia and your sarcoma patients are oftentimes younger and they're getting really high doses of this medication. So they have a potentially longer life expectancy dealing with fairly high doses of a toxic medication. Breast cancer is everywhere. A lot of the women who have it have a lot of risk factors built up over time and are older. So there's certainly some risk with that population. So I think, historically the thought was that you really didn't see too much issue with anthracyclines till you got to a fairly high dose, maybe around 400 milligrams per meter squared. And so, most regimens don't hit that. Most standard regimens, the R-CHOP that you would get for leukemia gets around 300 milligrams per meter squared. Most breast cancer regimens top out around 250. But over time, what it looks like is really your inflection point is actually at around 250, where your relative risk really goes up quite a bit. And so no dose of this is safe to begin with. You can have an issue at pretty much any dose, but it's certainly a cumulative issue. As you build up over time, it's a higher risk. And most regimens that people receive are over 250 milligrams per meter squared, so there is some risk associated with it. So again, if you look at this, this is symptomatic heart failure, 5% of patients who receive a dose of 400 milligrams per meter squared, and 16% at 500 milligrams per meter squared. And it's not uncommon that I see patients with doses this high, particularly sarcoma patients. You'll also see asymptomatic changes in LV function over time. So this is 200 patients treated with anthracyclines with a median dose of 450 milligrams per meter squared, which again today would be on the rare side, but 23% of those had some abnormal echo finding, which is either a decrease in LV systolic function or diastolic dysfunction, and 38% of those at 12-year follow-up had some abnormality, which is a pretty large number. Again, if you look at adult survivors of childhood cancer, at 18 years, 43% of them had some degree of systolic or diastolic dysfunction. And so you are seeing late long-term effects of this therapy in patients. And so this is something new. This is from the last couple of years. This is fulminant myocarditis related to immune checkpoint inhibitors. So again, this was something that wasn't noted until after it had been on the market for quite a while. Again, there wasn't a large safety signal that this was an issue. Certainly you had a lot of immune activation events, but not really a lot of cardiac events. And then patients started coming in who were on these checkpoint inhibitors, really, really sick, a lot of arrhythmias, and dying very quickly. And so they discovered that there was myocarditis potentially related to this. Seemed to happen most often in dual checkpoint inhibition. And again, initial studies, if you looked at it, the rate of events was pretty low. But over time, that number seemed to go up considerably, probably around 1% of patients receiving dual checkpoint inhibition. Usually this happens within the first 30 days of receiving therapy. Again, this is something that presents fairly overwhelmingly in these patients and wasn't discovered until after the drug had been on the market for a while. So, it's not just two medicines, it's actually lots of medications that have potential cardiac effects. Your HER2 new inhibitors, like Herceptin and pertuzumab, can cause LV dysfunction and cardiomyopathy, and that's something we see a fair amount in breast cancer patients that get monitored over time. Your VEGF inhibitors that you see in treatment for renal cell cancers, for instance, will cause hypertension and potentially LV dysfunction. Tyrosine kinase inhibitors can represent as peripheral arterial disease and thrombosis, pulmonary hypertension. And then your antimetabolites that you use in treatment of colon cancers and GI cancers can cause ischemic events. And so I'm going to go just to a second case here. And this was during my residency. I saw this patient. This was a 34-year-old female. She was 32 weeks pregnant, entered the ED with 10 days of shortness of breath. She had a history of Hodgkin's lymphoma 13 years ago, during which time she was treated with anthracyclines and a large dose of mediastinal radiation. So we kind of think of the inflection point of around 40 gray of radiation. When she would have received this, the heart blocking would have been pretty poor, and so she would have gotten quite a bit of this overlapping her heart. And so she'd followed with her oncologist for a couple of years and then said, "Oh, you're fine. You don't need to see anybody anymore. You're through the window where we worry about things." And she really hadn't seen anybody other than her PCP after that. So she arrived very hypertensive, desatting on room air. And this initial image from our echo shows some heavy calcification of this anterior mitral valve curtain, which is something that's fairly common in prior radiation. And subsequent images showed severe mitral regurgitation. At this point, at a lower blood pressure. So she had thickening of the mitral valve, retraction of the posterior leaflet, and severe MR. She was treated for hypertensive emergency and acute heart failure with diuretics, nitrates, labetalol, non-invasive ventilation. She underwent emergency C-section. Her symptoms improved. Her MR went down to moderate with control of her blood pressure and fluid. But this is a case where this is someone who should have been monitored long-term. Someone who received that amount of radiation therapy and chemotherapy should have had, per guidelines, an echo at 5 years and then every year afterwards. And so this is somebody who you could have had a really bad event here. You could have had the mother and the child die because of lack of appropriate follow-up over time. So this is the other part is, you've treated somebody through their cancer, now they're better. You still, doesn't mean that there's no risk going forward. And this is kind of what this illustrates. We have different kinds of survivorship, right? We have the cancer patient, you treat them, they're older, they're in their 50s, 60s, and they get heart failure afterwards, and that's bad, obviously. But, what's probably, I think, even worse, you have somebody who's very, very young, you treat them, you kind of ignore their risk for 20 years, and then they die, in their 40s. And that's massive numbers of life years lost that could have been prevented if you just appropriately followed them over time. If you look at this again, your incidence of heart failure over time goes up for those patients who have received radiotherapy and anthracyclines. Again, this is, particularly this population, you're looking at older women with left-sided breast cancer would have received this regimen, and then Hodgkin's lymphoma patients, particularly in the 90s. Those patients are really bombarded pretty aggressively with both of those. And there's been some dynamic change, certainly. But if you look at this, versus your age-matched sibling, 11%, 12% at 45 years versus basically none. And then the incidence of radiotherapy, of coronary artery disease with your radiotherapy patients, again, 9% at 45 years versus very little in an age-matched sibling. So you're seeing massive increases in incidence of disease based on the therapy these patients receive pretty young in life. And again, this kind of is talking about kind of the dual hit hypothesis that, if you receive an anthracycline, yes, your relative risk is 8%. If you have hypertension as well, there's some risk, but you add those two things together, it's a multiplicative cumulative risk. So if you have a young patient who's receiving anthracyclines, you really need to manage their risk factors, because over time, if you let them be hypertensive and don't monitor it, they're at much, much higher risk of having congestive heart failure at a later date. Same general idea with coronary artery disease. You have to manage their risk factors aggressively. Otherwise, there's a higher relative rate of risk for coronary disease. And so, this kind of illustrates the field in general. You have those things that I think everybody kind of knows about to some degree, and some of these we've talked about, right? Anthracyclines, HER2 targeted therapies. These are things we know a little bit more about. But there's some things that are under the surface that are developing. As these medications come out, we know less about them. We start seeing events more and more. And so, some of the things we see, right? Nobody thought about these cancer immunotherapies, cardiomyocarditis, cancer survivorship's really ignored quite a bit. We've seen an increase in arrhythmias related to these BTK, these Bruton tyrosine kinase inhibitors, particularly ibrutinib. Will present with quite a bit of AFib. And actually, interestingly, some of these early generation agents also have platelet inhibition. And so this is a population who are generally on anticoagulation and their platelets are inhibited. So their bleeding risk is actually quite high. And I had a patient actually just this week who I saw who had an intramuscular hematoma because they were on anticoagulation and ibrutinib. We ended up switching to one of the second generation medications that has less platelet inhibition. So these are things, you maybe don't think about right off the bat that can really have, potential pretty severe effects for patients if you don't know that data. So what can we do with these patients? So you know, certainly you want to monitor them. Part of this is picking out who's the high-risk patient, and I think it's kind of the holy grail is to figure out who is at the highest risk, who can you treat early on to avoid events, and I don't think we're quite there yet, to be honest. But the general thought is if you're on HER2 new inhibitory agent, you should get an echo every 3 months. If you're on an anthracycline, you should get a baseline echo. You should reassess once they hit this point of 250 to 300. And then you should probably, you know, as the doses get higher, keep an eye on them over time. Now, you keep an eye on them, great. What do you do from there? So I think this I think illustrates why it's so important to actually monitor these patients. So this was a paper done from a group in Milan where they looked at the response that the patients had after they developed heart failure to typical goal-directed medical therapy, you know, like beta blockers and ACE inhibitors. And essentially what they found was if you caught the heart failure within the first 6 months, but particularly the first 2 months, that 64% of those patients responded to therapy and had at least improvement or normalization of their EF. But if you didn't catch anything after 6 months, if you didn't get an echo, you didn't monitor them, there was 0% of those patients recovered. And so that also translated into hard cardiac events. You know, for your responders, you had basically very few events after the EF improved. You know, you had some life-threatening arrhythmias, but when you compare that to the non-responders who had, you know, sudden cardiac death, more life-threatening arrhythmias, heart failure, you were really preventing quite a number of hard cardiac events, which at the end of the day is what we care about more than anything. So it speaks to the fact that we have to monitor these patients so that we can catch issues before they get really bad to get them better. But part of that is that you have to be suspicious, you have to monitor them aggressively so that you can prevent events. And that's, again, this is like what happened with that first patient. You know, we were monitoring them, we saw that things weren't going in the right direction, we stopped therapy, we started heart failure medication, and they responded. And that kind of treatment prevents hard adverse cardiac events. Can we prevent cardiotoxicity? And I think this is probably where we're kind of lacking at this point in a lot of ways. You know, there have been some studies that have looked at, you know, changes in baseline EF by initiating medications like enalapril, carvedilol. And really, it's not that impressive, partly because you're just looking at gross changes in LVEF that are pretty small, partly because this doesn't actually reflect hard cardiac events. So the truth is, not a lot of great data about preventing cardiotoxicity ahead of time. Part of that is because, you know, in a lot of these studies, you're just treating everybody, all comers, rather than really selecting the patients who have the highest overall risk. Now, you know, there was some data that there were decreased treatment holds in patients who received beta blockers. You know, that in itself is not insignificant, but in terms of really preventing hard cardiac events, we don't have a ton of data at this point. And so I think, again, it becomes a question of who's high risk. How do we pick those patients ahead of time? So survivors, what do we focus on? I think a big thing is patient education. Of course, part of the problem with that is that, you know, we don't see these patients until an issue happens a lot of times. The patients, you know, should be told up front by their oncologist, particularly, you know, if you're talking about pediatric cancer survivors, by probably their pediatric oncologist, but this is a lifetime issue that needs to be followed up on. And so, you know, what's important is to aggressively adjust risk factors. So, you know, part of that is, you know, making sure they don't develop hypertension, bad habits over time. Part of that is understanding that for patients who've had radiation at a young age, they have an increased risk of coronary disease. and that they probably are people who are at a higher need for a statin at a younger age. You know, this is where coronary calcium score a lot of times will come into play. You know, you'll see people who are pretty young in their 30s who have a score of 400 because of radiation and chemotherapy in the past. And so their coronaries are older than their given age. And so it's, you know, being cognizant of that. And then, you know, appropriate screening. You know, so children should actually have pretty aggressive echo screening over time, you know, sometimes on a yearly basis. And for adults, you know, we generally recommend getting an echo at least 5 to 10 years after radiotherapy to look for valvular heart disease. You know, if you look, and this was a study that looked at care of pediatric cancer survivors. If you look at receiving appropriate echo at the appropriate recommended intervals, even at a cancer center with a long-term survivor follow-up program, it was only 50% of the time. If you look out in the community, it is only 20% of the time. So again, this is how you miss issues over time, is by not having appropriate follow-up. And this is one of the things a lot of people have been looking at trying to improve, but it's hard because it starts with education. So again, what do we do? It's modify risk factors, control blood pressure, screen the patients for statin use, discuss weight loss and diet and exercise. So who should we think about referring in the hospital setting? I'd say the patients with a history of chemotherapy use or receiving chemotherapy who present with LV dysfunction, even if they're asymptomatic. And that's a key because a lot of times they won't be asymptomatic for long. If you have a cancer patient who presents with a P or a DVT or new onset AFib, you need to have a discussion regarding the appropriate anticoagulation treatment. You know, that's an appropriate consult. Anytime you have a chemotherapeutic agent in a cardiac patient, you don't know if, or cardiac issue, and you don't know if they're related, that's an appropriate thing. Really, we want you reaching out anytime there's a question you have about these patients at all in the hospital. That's what we're here for. In the clinic setting, you know, I think, again, for people out in primary care, survivors of pediatric cancer are really a really high yield population that requires screening. So those who've had radiation in the past or high risk medications, especially if they have concerning cardiac symptoms, but even if they don't, a lot of these patients should really be screened intermittently with echoes, or we can see them and set up some sort of interval plan to look at things like their coronaries with a coronary CT and modifying risk factors. And again, even if these patients are pretty young, it's appropriate. Adult survivors of left-sided breast cancer or mediastinal radiation who are greater than 5 years out from their radiation, those are patients who should have an echo because of, again, the risk of valvular heart disease. You know, this left-sided radiation, breast radiation, may be changing a little bit over time. It seems like with the current techniques, you're seeing less heart scatter. But for a lot of the patients who received their radiation, you know, 20, 30 years ago, this is still definitely an issue. And then anybody who's received chemotherapy who's having a concerning cardiac symptom, syncope, chest pain, shortness of breath. These are all appropriate referrals. And if you have any of those patients, you know, or you have questions or concerns, I'd encourage you to reach out, either give me a call, send me an email, and I'd be happy to discuss them and come up with a plan for anybody. That's all I've got. If anyone has any questions, I'd be happy to answer them.
Did a good talk, Patrick.
Thank you.
Anybody on,
Patrick, let me ask you a question. So should we think about some of these patients like ECC stage A? You know?
Yeah, I would. Yeah, for sure.
Can you repeat that for the?
Yeah. So what Dr. Maniam asked is if we should think about these patients as ACC grade A type patients, so basically those with risk factors, structural disease. And I would, yeah, 100%. They definitely do, because their lifetime risk is so much higher than an age, you know, because we talk about hypertension. This is much higher risk than hypertension. So yeah, absolutely. This is, you know, a non-modifiable risk factor to some degree that just really requires much more aggressive management than the average person.
And then when you talk about echo and then looking at echoes, post.
Yeah.
What's the time frame? Because acutely, do they check echoes on everybody who get these agents or?
Yeah. So in terms of the echo follow-up, so if you have someone who's on Herceptin or pertuzumab or something like that, it's every 3 months. That's like pretty standard. Everybody does that, and then one when they finish. With anthracyclines, it's really hit or miss. Pretty much everyone gets an echo baseline. That's kind of standard of care. Whether or not they get them throughout the rest of their therapy is much more up in the air. So I think if people get huge doses, they'll get it for sure. The problem is that you start to see an inflection point at that 250 to 300, which is like a basic regimen for anybody. And sometimes those people don't get a follow-up echo afterwards. So I definitely say that anybody who gets an anthracycline at the end of their chemo within 2 months for sure should get one.
So it almost seems like if you're going to get an echo on these patients, and we're saying they're ACC stage A, and they need some kind of linear follow-up, that probably they should establish with someone who's going to kind of follow them linearly.
Yeah.
Because the rates of progression
Yeah.
can be much longer than what people would expect, I think.
Right, yeah. I mean, you start to see events way down the road. I mean, some systolic dysfunction, but yeah, diastolic heart failure too, right? Down the road. So yeah, I mean, you would like to have these patients plugged in appropriately for longitudinal care. Yeah, adults definitely, kids absolutely should be. Yeah, great question.
Patrick, I don't know if you can hear me.
I can.
This is Jigme. I have a question about these patients who've had previous mediastinal radiation and or chemo for Hodgkin's, non-Hodgkin's, etc. And 30 years out, they've got severe calcification of the valves. Are these valves amenable to replacement, either open surgery or transcatheter replacement because of the degree of calcification? And the second related question is, if you pick them up when the calcification is first developing, are they at that point amenable to being treated? Or is the calcification of the ring and everything else precluding them from getting valve surgery?
Yeah, so that's a great question. So actually they have looked at this. The surgical outcomes in these patients are actually much worse than age-matched groups. And part of that is because of the amount of radiation they've received, the scar tissue they've built up, particularly in their chest wall. So they are amenable to it. It's just a much higher risk procedure. It is definitely one where they're looking at transcutaneous valve replacements much more because of that high risk of surgery. So yeah, I think they're probably better served by transcutaneous valve replacement, even though that, again, is not easy because of the amount of calcium. I think either way you look at it, it's a high risk procedure over time, definitely.
Thank you.
Yeah, thank you.
Thanks a lot.
All right, thanks guys, appreciate it.